I'd like to thank the organizer of the conference for providing me with this opportunity to present my research interests as well as my research project on kynurenine pathway and cancer. And in today's talk, I'll be talking about a brief introduction to cancer, the role of kynurenine pathway in cancer, clinical trials examining kynurenine pathway inhibitors, and last but not least, the research project that I've been working on in Professor Guillermo's lab on kynurenine pathway and breast cancer. First off, what's cancer? Cancer is a disease of cells that grow in an uncontrolled manner and spreads into the surrounding tissues. And according to World Health Organization, cancer is the leading cause of death worldwide, resulting about 10 million deaths this year. And the top 5 cancer-related deaths are lung cancer, liver cancer, stomach cancer, female breast cancer, and colon cancer. And if you can see the figure on the right, you can see that most of the cancer-related deaths are reported in the Asia, followed by America. And cancer can be categorized in various stages, and it differs from one cancer to the other. And in this talk, I'll simplify it to 2 stages. The first stage consists of cancer developed in an uncontrolled manner but contained within a locality. This means that patients diagnosed with early stage cancer tends to have the best prognosis, where it can be removed surgically and has the lowest risk of relapse. However, if cancer continues to remain undetected to grow, they then proceed on to late stage, which is metastasis, where the cancer actually breaks its boundary to invade surrounding tissues and other parts of the body. So patients diagnosed with this stage of cancer tends to have low survival rate and tends to have the worst prognosis. And for cancer to develop from early stage to metastasis, it needs to have accumulate a number of factors. So these are known as the hallmark of cancer. So if you read from the top in green, it needs a sustained proliferative signaling, evade growth suppressors, activating invasion and metastasis, enabling replicative mortality, inducing angiogenesis, and cancer resisting cell death. And as technology advances, there's more hallmark has been suggested to add onto this existing hallmark, and they are the emerging hallmarks such as deregulating cellular energetics, avoiding immune destruction, and in enabling, you can see there's genome instability and mutation and tumor inflammation. And among all these hallmarks, KP has shown to have a strong association with the emerging hallmarks of deregulating cellular energetics, avoiding immune destruction by providing energy for tumor repair and growth, and at the same time avoid immune detection. So what's KP? As presented by Professor Guillermo yesterday, KP is a biochemical pathway that catalyzes tryptophan to generate energy for the cells to repair and divide. And this pathway is usually in a very strict controlled manner under healthy control condition. As you can see, IDO1 and TDO2 is the rate limiting enzyme of the pathway. And after breaking tryptophan down, there's a series of KP metabolites marked in red, shown to have bioactive activity and able to induce cell death. And the pathway tends to operate in a linear manner where tryptophan is being catabolized into series of metabolites to derive NAD+, which is the energy for cellular repair. Next, you might ask or wonder, how is KP involved in immune response? So the ability of KP to mediate immune response actually comes in a study led by Professor Mann in the US, where they noticed or observed that IDO1 is highly expressed in the placenta. And this actually prevents maternal immune system from attacking the fetal across the placenta. And in the same group, they treat the pregnant mouse with an IDO1 inhibitor that to stop the activity of IDO1 in the placenta. This allows the immune system from the maternal side to cross the placenta and attack the fetal, leading to fetal rejection. And as shown in the study, they then, given that KP is able to manipulate or mediate immune suppression, they thus wonder like whether tumor has the same ability, given that KP is expressed across almost all cells. And true enough, in the study led by the same team, they noticed that the tumor in the breast cancer mouse model, which is the MMTV nude HER2 mouse, the tumor expressed high IDO1 activity. And when they treat this mouse with an IDO1 inhibitor, it led to a slowed tumor growth. And interestingly and excitingly, when they combine it with the chemotherapy drugs, it actually caused a regression of the tumor. So now you might wonder, so how is KP involved in cancer progression or development? And this can be broken down into 3 different mechanisms, as you can see in the figure on the right. The first mechanism will be the tryptophan depletion or starvation. Tryptophan is an essential amino acid for immune cells survival and proliferation. And if you can see on the figure on the right, IDO1 and TDO2 tends to be highly activated in tumor cells that depletes the tryptophan in a microenvironment. And given that it's an essential amino acid, this stops the CD4 T cells, which is a tumor targeting cells. And by stopping it from growing, tumor cells able to continue to proliferate. The second mechanism is the production of bioactive metabolites, which are highlighted in the slide earlier, which is 3HK, 3HA, and queen in green, turquoise, and dark blue. These 3 metabolites have been shown to inhibit, again, CD4 cell proliferation in a micromolar concentration. And finally, the last mechanism, which is the hydrocarbon receptor activation by kynurenine, which is the first product of the pathway. It is an endogenous ligand that binds to this AHR, and AHR receptor is expressed in almost all cell types in the body. However, binding to this cell type in various cells achieves different outcomes. For example, when it binds to the cancer cell itself, it enhances invasion and local inflammation, as you can see mark 3 here. And when it binds to the AHR expressed on CD4 cells, it actually causes it to undergo cell arrest. And inversely, when it binds to a group of T cells, which is called the T regulatory cells, they are known to suppress immune surveillance. It actually causes this cell population to proliferate. And this task creates an immune exclusive zone around the tumor. And given that, or considering that an inhibitor to the pathway is one of the most popular choice for treatment, KP IDO1 has now emerged as one of the popular targets to regulate or to stop this activity. And currently, there's up to 97 different clinical trials examining IDO1 inhibitors. And these are the 3 prominent companies that manufacture and involved in clinical trials, which is the Incyte, Newlink Genetics, and BMS. And here are the various inhibitors provided or generated by these companies. And if you can see from the number of clinical trials, ipacadoside is the most popular one, which is involved in 59 because it has the highest IDO1 inhibition efficacy. And the next 2 will be the indocimod and BMS inhibitor, where they're involved between 15 to 20. And from the clinical trials, it's been reported that these inhibitors are well tolerated with no increase in toxicity observed in patients. And the most common treatment emergent adverse events are fatigue, nausea, and anemia. And considering that these are in clinical trial, I'd like to highlight to you 2 of the prominent clinical trials happening now. So the first one would be the ipacadostat, which is the NCT 02752074, which is the idea of the clinical trial. This looks at the combination therapeutic treatment of ipacadostat with pembrolizumab, which is a checkpoint inhibitors in patients with unresectable or metastatic melanoma. At the conclusion of this clinical trial, they observed or reported that patients receiving a combination therapy show no difference with the groups receiving the pembrolizumab only. And given this conclusion, this clinical trial did not proceed on to phase 3. This negative result actually led to a series of termination or pause in enrollment in other multiple IDO1 clinical trials. But I'd like to highlight or bring to your attention to what might have led to these negative results. First of all, inhibiting IDO1 alone might not be sufficient because studies has been shown that inhibiting IDO1 would have a compensatory mechanism of IDO2 and TDO2, where they became the prominent enzyme to drive the pathway. And next is in this clinical trial, the patient is actually not being screened. So they have no idea whether the tumor actually express IDO1 or not, or even TDO2. Hence, the result is not as positive as you would have if it's been screened. And these 2 points thus highlight the gaps in creating ideal clinical settings to evaluate IDO1 inhibitor efficacy. The next example I'd like to highlight to you is indocimod, which is the clinical idea of NCT 02073123. This clinical trial also looks at patients with advanced melanoma, where they evaluate combination treatment of indocimod with either one of the immune checkpoints. In contrast to ipacadostat, they actually observed that patients treated with the combination therapy of pembrolizumab with indocimod has a higher objective response rate as compared to patients with just pembrolizumab only. This means that patient undergoing or receiving the combination has a lower tumor burden or a reduction in tumor size as compared to patient with who receive only the checkpoint inhibitors. And given these positive results, it has now proceeded to phase 3 clinical trial. And as you can see from this example, it highlights that patient selection seems to be crucial or essential to have a clinical trial that can critically evaluate IDO1, and hence where my research project comes in, where we see whether we can use KP activity to screen for patients with breast cancer, which is what I'm doing in Professor Guilliman's lab. And this work has actually been published last year, where we look at KP expression in different breast cancer subtypes. To start off, I'll give you a brief introduction of breast cancer. So it is the most diagnosed cancer cases and the 5th cancer-related death worldwide. And it can be classified into subtypes according to its molecular characteristics. But for this talk, I'll simplify it to 3 major breast cancer subtypes. They are luminal, which depends on estrogen, HER2 enriched, which depends on the growth factor HER2, and triple negative, where it depends neither the hormone or the growth factor. On the y-axis is the risk of recurrence, where the lowest risk at the bottom, as you move up towards vertically, is risk of recurrence increases. And the x-axis is the prognosis, where on the left is the best prognosis. As you move towards to the right is the worst prognosis. As you can see, triple negative has the worst prognosis and higher risk of recurrence as compared to luminal and HER2 enriched. The reason to this is the absence of targeted therapy. So you can see that patients with luminal breast cancer subtype tends to have tamoxifen as a treatment, while patients with HER2 enriched breast cancer have the trastuzumab as a treatment. Interestingly, in patients, the triple negative tumors has the highest number of infiltrating immune cells So there's a lot of immune cells around this tumor, but somehow the tumor is able to evade the immune surveillance or detection. And thus this suggests that perhaps these cancer cells have immune evasion ability to stop them from being detected by immune cells. Hence, the immune system is unable to control the cell growth, the tumor cell growth, of course. And this then led to the suggestion that perhaps immunotherapy might be a good treatment for them. And one of the target for immune therapy is the kynurenine pathway. So then that leads to the next question, as in, what do we know about kynurenine pathway regulation in breast cancer? There's about up to 20 studies now done, but I only highlight a few here in this talk. And I'd like to bring your attention to the number of the studies. They only look at the first enzyme, IDO1, and the first product, the kynurenine, in patients. And given that there's so many studies looking at the same marker, thus let me wonder whether it's IDO1, KAP activity limited just to IDO1, and that whether, given that they are all different subtype, different molecular profile, would KP behave differently or similarly across these pathway or subtypes, sorry. To do this, we then look at the mRNA expression of the KP enzyme in tumors. And this is done by using patients' sample or mRNA array data collected in by molecular taxonomy of breast cancer international consortium cohort in collaboration with a collaborator from University of Newcastle in Sydney, Dr. Milio, Professor Moscato, and we look at a total of 1,500 patients and 144 healthy control. And in the IDO1 tumor expression, we saw that triple negative has the highest expression, followed by HER2 enrich. When we look at the second enzyme on the pathway, which is KMO, we saw that HER2 is actually highly elevated, followed by triple negative and Lumina. They seem to have the same expression. And when we look at the third enzyme down of the pathway, we saw that triple negative and HER2, and which again has the highest expression. There's no difference between Lumina and healthy control. And given that mRNA is not necessarily translate the protein, we then look at the protein expression and tumor slides. So we look at we do immunohistochemistry, looking at IDO1, KMO, and KYNU, as you can see in the slides here, and the corresponding negative control, which is the isotype control, to show the specificity. And the profile almost matches what we see in the mRNA, where Lumina has low expression across 3 different enzymes, while triple negative and HER2 enrich has high expression of IDO1 with KMO or KYNU. After seeing or examining the protein expression, we next wonder, like, okay, would that protein be active at all? So next we look at the enzyme activity in patients' blood collected from Victoria Cancer Biobank, Australia Breast Cancer Tissue Biobank, and Strathfield Breast Cancer Center in collaboration with Dr. Bustamante from UNSW and Dr. Gluck from Strathfield Breast Cancer Center. We look at about 300 or almost 400 actually breast cancer patients and 98 healthy controls. And it's almost the same as what we see in the mRNA and protein profile. Triple negative and HER2 enriched breast cancer patients has the highest activity. And same goes for KMO and KYNU, where triple negative and HER2 has the highest activation. And in conclusion of all these 3 profiles, we conclude that patients with triple negative and HER2 enriched breast cancer subtype has the most KP dysregulation. And given that we can measure all this activity on the blood, next makes us wonder, well, can we actually make use of this data, given that we can measure the enzyme activity in different breast cancer subtypes? So next, we then collaborated with one of our university biostatistician, Associate Professor Lynch. We look at we put all this data into predictive marker modeling, where we try to see if we can identify triple negative patients from Lumina and HER2 enrich. And interestingly, with all these parameters we measured in the blood, we're actually able to identify patients with triple negative subtype with a 95.2% accuracy. And surprisingly, this accuracy is near to the current gold standard done in pathological lab to identify patients sampled by doing IHC or immunohistochemistry. And you can see it's about sub-90s from here. And this task suggests that perhaps measuring KP enable us to screen patients for who can benefit from IDO1 inhibitor treatment. And conclusion of this study, this first study showed that the pathway is not limited to just IDO1. Downstream enzymes are also active in these breast cancer cells, and that they might evade immune surveillance by tryptophan depletion by IDO1 and the production of immune suppressive metabolites, such as by KMO and KYNU. Next, the dysregulation is predominantly seen in hormone-negative breast cancer subtype, which is the triple negative and HER2 enriched. This task suggests that perhaps these two subtypes, KP is one of the mechanisms used by the tumors to evade or prevent immune detection. Last point, which is the measurement of the KP metabolite in pre-treatment breast cancer, has a high prognostic identification to identify patients with triple negative breast cancer subtype, and thus have the potential as a treatment response perhaps, or identify patients that might benefit from IDO1 inhibitor treatment. And on this, I'd like to thank Professor Guillermin Group and his ever long support of my work in breast cancer, and also various institutes on organizations such as the Breast Cancer Network Australia, hospital, and various collaborators from Research Institute, and most importantly, the funding for me to proceed with this or support my research. And at this slide, I'd like to thank your attention and the opportunity again to present my work. Thank you.